Oh, good morning. Happy Saturday, everybody. Welcome to Global Virtual Morning Report, or Virtual Morning Report for those of us for whom English may not have been or is not a primary language. Welcome. We're delighted to have you here, as per usual. It's a very sunny Saturday in San Francisco. My name is Robbie. I am one of the team members of the Clinical Problem Solvers, and I am originally from Lebanon. I grew up, I was born in a town called Zahle, which is about 30 minutes outside the capital, Beirut. And my parents actually worked in a Lebanese international school. So I spent most of my youth in Lahore, Pakistan. So I am lucky enough to have been exposed to Middle Eastern culture and South Asian culture and speak Arabic and Urdu. The whole point of Global Morning Report is to reflect on the scope of international medicine and bring our cultures and our nerdiness together on these Saturdays. We kind of do things a little bit differently. Sometimes we have volunteers from the crowd discuss with us, and other times we have Kiara and her puppy reflect on a case classroom style. And today we're up to actually for the 5 CP solvers to discuss a case together. We will still rely on you to bring a case. So if you have a case, please present it. And while somebody volunteers to discuss a case, we'll go and actually introduce you to the CP Solvers crew who is going to discuss the case. And in alphabetical order, we'll start off with Kara.
Hi everyone, I'm Kara, and I guess I speak Mandarin and Cantonese, mostly Cantonese fluently, and I guess I'd like to say good morning everyone, so dosan everyone, and I'm very excited to discuss with the team.
Hello. Thanks for joining us today. Kiara?
Yeah, it's my time, and just the plane is going here, so a little noisy right now. My name is Kiara. I'm from Peru. I'm so happy to be here, and my dog is happy to be here. I'm a medical student from Peru, and I speak Spanish. So I just going to say hola a todos y me encanta estar aquí con todos ustedes. Now it's time for, I'm not so sure, Rafa or Maria?
Oh, I didn't realize Maria was here. Maria, hello.
Hi. I was actually not gonna log in because I'm off a night shift, but then I was like, I'm already awake and I have to eat breakfast, so why not just eat breakfast in front of everybody in VMR, as usual. Yeah, so I'm Maria. I'm from Guatemala and estoy súper feliz de estar aquí un sábado también con todos.
It's a delight to have you here, my friend. Rafa, what's up?
Hi, everyone. My name is Rafael, and I'm a fifth-year medical student here in Brazil. Muito feliz de estar aqui novamente com todos vocês. Espero que alguém tenha algum caso que a gente possa discutir juntos e aprendermos durante essa jornada de diagnóstico clínico. É uma coisa que o Robbie sempre fala e uma coisa que eu acho que a gente tem que levar sempre, que o objetivo nunca é atingir o diagnóstico final, mas sim o raciocínio por detrás da jornada até o diagnóstico. Something that I really wanted to say is that Robbie always teaches it's not always about the final GX, but it's about the journey. That's something that we have to keep reminding ourselves here.
100%. You got to enjoy the view. All right, last but not least, Sukriti, please unmute yourself. And a reminder for folks, please, if you have a case, we'd love to hear it.
Hey everyone, I'm Sukriti, and Shubhratri for everyone who's tuning in from India because it's evening here. I'm calling from Bangalore, which is the southern tip of India, and I'm really excited for today's VMR.
Amazing. So it's a delight to have you here. Hey, Dhruv, I see your plug in the chat. Since we're recording, do you want to unmute yourself and plug verbally so the folks listening to the tape afterwards can hear what you have to say?
I feel like the plug, it would probably be more appropriate for some of the creators of that pop, like Rafa or Tiago to, but if you guys insist, So hello, everyone. For those of you who don't know me, I'm Drew. I'm a fourth-year med student from Richmond, Virginia. Submitted my rank list a couple of days ago, and now in the 2 weeks of waiting before match day. But just to explain that little shameless plug, Rafael, Tiago, Gabriela, and several other of our CP Solvers friends, I see Marcela in the chat as well, she's also part of it, have started essentially CP Solvers in Portuguese called Elabora Medicina. And a lot of us have been at least on the first few sessions, and trying to remember when the next session is going to be, but I encourage you all, if you are interested in seeing how clinical discussion happens in Portuguese with in sort of another environment, I absolutely encourage you to join it's essentially the CP Solvers community just translated, if you will.
Yeah, there we go. I love it. Thank you so much for that plug, Drew.
Mathieu has a case. Woo!
Yeah, it looks like Mathieu has a case. I also see that Gabrielle has a case. But Gabrielle, since you presented yesterday, we'll pass on the baton to Mathieu. But now I know you have a case, so next time I'm going to be counting on you, my dear friend. Mathieu, it's so great to see you again. Please unmute yourself and tell us a little bit about you, remind us a little bit about you. And on Saturdays, we of course have an international twist to the VMR. So I know a little bit about you from last time, and I would love to have that international tinge on display again today.
Yeah, so hi everyone, I'm Mathieu Bourgnier. I'm an emergency physician and a trauma team leader in Montreal, Canada, which is the French province in Canada. I will present to you a case that I saw actually last night on shift.
Whoa. Okay.
So full disclosure, I don't know the final diagnosis.
Perfect.
But I think just working through the first 8 hours that I spent with the patient is going to be interesting.
Amazing, amazing. And today we have 5 people who are going to discuss this: myself, Sukriti, Rafa, Chiara, and Kara. And I will leave it up to Maria if she wants to chime in. I'll make it very optional because she just finished a night shift herself. But I forget who. I'm sorry, I should have asked before, but I forget who's scribing today. If you don't mind taking over the screen, and we'll jump right into Matthew's case.
Yeah, so super excited to hear what you guys are gonna have to say about how things unfolded and see if there's anything I haven't thought about last night.
I highly doubt that, but we'll certainly. I forgot to make that. We'll certainly give it a shot. In the meantime, do you want to tell us a little about a cultural tidbit about where you're from in the world?
Okay, so Quebec, as you guys know, is the only French province speaking in Canada. Maybe one traditional thing about Quebec is poutine, which is a meal that is made of fries with a hot gravy on it and melted cheese.
Oh, that sounds absolutely amazing. When was the last time you had that?
3 days ago.
Oh, okay, good.
Yeah.
Good. I hope it's
a once a week event at home.
I see. Good thing I'm not in Quebec. I feel like I might have that once a meal event. That sounds absolutely delicious. Thank you. All right. Well, I think Chiara's ready for you, so please take it away.
Okay. So last night I was actually working the ambulatory sector of the emergency department, which I do not work often. Usually work the recess area, but once or twice a month, I work in the less acute sector. So I wasn't expecting a super exciting night. Picked up that chart of a 20-year-old male, referred to us with COVID day number 10, seen at a clinic earlier that day, and he was referred to us for persistent tachycardia above 130.
Above 130. Okay, wonderful. That's a
so
great.
that was the triage chart.
I love it. It's amazing how much our formulations are beginning in the face of just the triage. And so maybe we can start off with Sukriti in reverse alphabetical order. So really, I think it's always helpful to have a understanding of the lay of the land. What have you uploaded in your mind in terms of COVID? So what's your sort of short illness script for COVID?
So I think if I think about COVID in the format that we devised our illness scripts in terms of what kind of patients are affected. So we know that COVID affects people of all age groups, but tends to be more severe in the elderly. Um, the other is the geography. So we know that there are different strains now. We have the South African, the Brazilian, the California, and the New York strain. And so each strain has some differences in terms of the severity of illness that it causes, and also how infectious it is. I think the other would be in terms of defining the clinical syndrome. So we know that COVID has a whole range of symptoms. So patients can be can be completely asymptomatic, but we also know that they can come with some upper respiratory tract symptoms or lower respiratory tract symptoms. Something that is more specific to COVID and sort of differentiates it from another upper respiratory tract infection is the anosmia that we see with COVID. Um, and thinking about further the complications that COVID can cause, we also see that COVID causes a lot of vascular complications. Patients typically need some sort of anticoagulants, like we give them prophylactic heparin, because they tend to be more prone to vascular complications. We also know that we are seeing a lot of patients who have post-viral myocarditis and damage to the heart. And also speaking from the neurological perspective, we're seeing that COVID can also affect the CNS and the peripheral nervous system. So it's hard to sort of to define this syndrome, because we know that it affects all organ systems. So typically we think of something that is multi-system and inflammatory.
I absolutely love that. I absolutely love your description, then your summary. And your summary was essentially that COVID is a systemic disease whose center of gravity is the respiratory system, but it is a systemic disease. And you really made a great list of potential complications affecting the heart and affecting the vasculature. And I think we're understanding more and more the range of complications, and almost everything under the sun has been described as a complication, including Guillain-Barré, encephalopathy, acute tubular necrosis. But the ones to really tabulate, the ones that we consider to be common enough that we think about most of the time, is the thrombotic complications. And I thought that was absolutely beautiful. And your point about the asymptomatic dimension always makes us wonder, is what is happening to the patient as a result of COVID, or is COVID simply an asymptomatic bystander to a separate disease process? And that's always a tension in the case. Kara, how are you thinking about the tachycardia? So the COVID we've had, Sukriti is a great analysis of that, and I think we understand it. How are you thinking about the tachycardia?
Yeah, I mean, like sinus tach is always, if it's sinus tach, is always like a scary, it can be a scary thing because it can herald like a bigger underlying process. But I've always thought of it as like either a problem with the heart itself or a reaction to something that's happening either vascularly, like a PE, or bleeding. Like, so you're either like having like a physiologic response to like a problem outside the heart, or the heart itself is having a problem, like myocarditis, pericarditis, like something that's irritating the conductive system. Yeah.
I think it's a brilliant overview of tachycardia. Like the conceptual model is the heart just going crazy for no good reason, or is there a good reason for the heart to go crazy? And it's amazing what you can infer based on a little strip of electrical activity from the surface. Like you put you see somebody's heart is going fast. And then what we do, if you think about it for a second, is you put like leads on somebody. And if they happen to have the correct shape of a P wave before QRS, you're like, oh, the heart is responding appropriately to something else. This is sinus tachycardia. And I just find that absolutely crazy that you can literally put leads on somebody, study the shape of their atrial activity and be like, oh, this is heart appropriate or heart inappropriate. And the heart inappropriate is either a supraventricular tachycardia or a ventricular tachycardia. If you, Kara, if you had to guess, do you think it's going to be sinus or not sinus?
I mean, I have no reason to believe it's not sinus, especially because he's coming in post-infectious. So yeah.
100%. I think that's the key point. Like, we don't really know until we get an EKG, but we make educated guesses. And whenever the center of gravity of a case is not the heart, because whenever the center of gravity case is not the heart, we infer it's sinus. So somebody comes in with tachycardia and abdominal pain, or tachycardia and headache, or tachycardia and anything else. But if all they come is tachycardia and all they're saying is palpitations, the overwhelming odds are is they'll find an arrhythmia. So really is, what is the company of the tachycardia? And if the spotlight is on the heart, it's probably not sinus. But if the spotlight is elsewhere, here COVID, it probably is sinus. I think that's a very good rule of thumb. So Chiara, if Chiara's telling us, hey, this is probably sinus, if you focus in on just sinus tachycardia, we can't assume that yet, but we should have an operating assumption. How do you think about sinus tachycardia?
It's so funny because I always confuse when you say Cara and Chiara.
Yeah.
I hope you ask me.
Yes, I did.
Okay. So sinus tachycardia, I like that because common things are common, right? So when someone with sinus tachycardia, I think that fever goes with tachycardia, and fever is very broad. So this can be consistent with COVID-19 day 10, maybe COVID-19 resolution, or some complication with pneumonia that is exacerbating his fever and with that tachycardia. So now I'm thinking all the possibilities of fever that goes with COVID-19 complications. Then other common things for sinus tachycardia is exercises. Every time you exercise, you have tachycardia. So
I can confirm that right now.
Yeah. So however, this is a persistent tachycardia, so I don't know if this is 2 days, 3 days, or all the 10 days with this disease. Also, sinus tachycardia goes with emotions or stress,
Yeah,
or pain. So that's something I can be thinking about. But with sinus tachycardia, bad things that I hope this is not the case also goes with severe anemia, shock, or drugs, or alcohol abuse, or alcohol withdrawal. So I hope it's related to something good and not these common causes that can be bad.
100%. I think you did a great overview of sinus tachycardia. And what I will do is I will try to make it something that you can teach somebody. So my goal in the next 2 minutes is to actually make sinus tachycardia much simpler, because the question is often with sinus tachycardia, what is it not? It could be so many things. You listed about 10 things right there, Chiara. How do you make it simple? Sinus tachycardia is either physiological sinus tachycardia in response to a severe endogenous issue, or it is pathological. What am I trying to say? Kara said tachycardia is either inappropriate or appropriate. Either it's SVT, VT, or sinus. Once you're in sinus, you still have to ask a similar question. Is the sinus tachycardia in response to something, or is it itself pathologic? So even sinus can be inappropriate. And let me explain why. All sinus tachycardia is as a result of increase of catecholamines. That's how we increase our heart rate. And the key question is, are catecholamines being secreted excessively in response to a physiological stimulus, or are they being secreted in response to a pathological problem? And that's where you break down sinus tachycardia into the 2 S's, shock or sympathetic toxicity. And I'll explain what those 2 mean. Sinus tach is either a fever, shock, or sympathetic toxicity. everything that can cause shock, from distributive shock like sepsis, cardiogenic shock like a valve rupture, hypovolemic shock like severe anemia that you mentioned, or obstructive shock like PE can cause sinus tachycardia. And this is all physiologic. Your heart is pumping faster and harder to prevent you from dying. Okay? But you can have sinus tachycardia completely unrelated to you being about to die. And that's because you took something like cocaine or albuterol, or are withdrawing from something like alcohol, or you have hypoglycemia or pheochromocytoma or hyperthyroidism. Those things will not cause you to imminently die. You have increased sympathetic activity that is resulting in sympathetic toxicity. What's your clue? These patients usually have lowish blood pressure driving compensatory tachycardia. These patients usually have catecholamine excess without any deficiency. So they'll be hypertensive and tachycardic. Does that make sense? So the key question with tachycardia is it sinus or not? Is it appropriate or inappropriate? But sinus tachycardia may also be inappropriate. This is all inappropriate. You don't need the sinus tachycardia when you have cocaine. You don't need it. It's there because of something inappropriate. So ask yourself, is it one of the two S's? Is it shock or is it sympathetic toxicity? And you have to assess this before you move to sympathetic toxicity. And what's your clue? The blood pressure. If the blood pressure is lowish, it tells you your body's trying to compensate and make your heart rate go faster. If your blood pressure is really high, your body's like, why the hell do I need to be in sinus tachycardia? I don't need it. It's probably sympathetic toxicity. I'll give you a brief, more extensive overview of sympathetic toxicity and then leave it at that. Give me 1 second. Oops, sorry. Because I think it might be worth it. And then we'll move on. Okay, there we go. Ready now. So what is sympathetic toxicity? It is increased sympathetic tone without shock. Non-physiologic increase in sympathetic tone. Is it because you took a drug, cocaine or caffeine, or you're withdrawing from a drug that usually dulls your sympathetic tone? Is it because there's a medication effect like albuterol or serotonin syndrome, or NMS, things like that? These are exogenous. These are from the world. Endogenous causes are things like you mentioned, Chiara, pain or anxiety, hypoglycemia, all these things. I just wanted you to take a quick view of them and then we'll move on. I'm going to summarize one big teaching point, and we'll ask Rafa to summarize one other one that I think is important in this case in Portuguese. The biggest teaching point for me was what the combination of Kara and Chiara said. First, when you see tachycardia, is it sinus or not? And then if it's sinus, is it compensatory increase in sympathetic tone, like shock, or is it pathologic increase, like cocaine toxicity? Rafa, what stood out to you in this aliquot? And please tell us in Portuguese.
Eu acho que o que mais é muito difícil trocar de língua. Pera, deixa eu pensar um pouquinho. O que mais que foi um highlight para mim foi dividir então em causas intrínsecas e extrínsecas. Quando é intrínseco, geralmente é algum problema no sistema de condução do coração, então, por exemplo, uma taquicardia ventricular ou uma taquicardia de origem supraventricular, mas também a gente deve lembrar das causas extrínsecas, a gente chama de taquicardia sinusal, que pode ser uma resposta fisiológica ou patológica. Uma resposta fisiológica, por exemplo, infecções, mas patológicas pode ser, por exemplo, choque, ou então uma toxicidade simpatética, ou então pode ser devido a tumores, como o pheochromocytoma. E eu acho que uma coisa muito legal de poder distinguir as duas seria olhando pelo ECG, então. That's basically it. I just added something that I think one good way to distinguish both is to look at the EKG. So you can see that if there is supraventricular tachycardia or ventricular tachycardia, you know.
Excellent. All right, you're up next, Rafa, to discuss. But for now, I'll have Matthew give us more of it, please.
So I'll now give you some more story, the physical examination, the point of care echo, as well as the first ECG, because that's basically the tempo at which information came in real life. Rest of the vitals were temperature of 38.5. That was buccal. Blood pressure was 117/54. Heart rate was measured again at 132. His rest rate was 22, and his O2 sat was 99% on room air. So the patient told me an history of being febrile persistently for 10 days, which prompted him to visit the clinic on that day. He complained of a mild shortness of breath, but nothing like other COVID patients that we see. No chest pain, no GI symptoms. He just felt overall weak, and he could feel the tachycardia. And he just thought his symptoms were lasting longer than expected. So that's why he presented on that day. There was not really much more on the history. In terms of past medical history, he is not known for any medical problem. He's not taking any medication. He's originally from Algeria, moved to Canada at age 6, and haven't traveled out of the country for the past 5 years. He is not a smoker, does not drink alcohol, does not take drugs. He has no allergy, and he's a full-time student. Point of care echo showed RV that was smaller than the LV as expected, no pericardial effusion. I was wondering about some regional wall motion abnormality at the apex of the heart. There was B-line in both lung fields, and there was no DVT on my point of care examination. The ECG showed sinus tachycardia with high voltage in the anterior and lateral leads and diffusely inverted T waves. We didn't have any previous ECG to compare it to.
That's super helpful.
And I'll stop there.
Super helpful, Matthew. Thank you so much. It's such an intriguing evolution. And maybe we can just do it in the order we received it. So Rafa, when you hear this, Sukriti gave us a great illness script for COVID. And we hear that the patient is persistently febrile for 10 days and has mild shortness of breath, no chest pain, and GI symptoms. What did you do with that when you first heard it?
So I think Razel would not forgive me if I didn't start saying his famous mnemonic. Like every time we have fever here, we have to think about the IMA pneumonic infection, malignancy, autoimmune drugs, endocrinopathy. And Drew always reminds us to think also about thrombosis, so which could be in place since this patient is post-COVID, and we know that it has thromboembolic complications as well. And another thing that I learned from you with fever is to always think about 4 questions. Who is this patient? Like this patient, he's post-COVID, like is he immunosuppressed because of the therapy that he received? Like maybe his immune response is not answering appropriately after only 10 days. So we could think about hospital-acquired infections as well, or community-acquired infections that this patient may be exposed to, which is inside of the other question, which is where, which is the community factors that the patient may be exposed to, but also when, which is 10 days, and what, which is the clinical syndrome. So another thing that I was thinking about is we see that this patient has 99% on room air. So I was thinking about COVID-related lung injury, but I don't think it's at play here because of the good saturation that this patient is having. And also his EKG showed inverted 2 waves. So I don't know what to think about it, because inverted 2 waves is a sign of...
Greedy to put her head for it. I'm giving her a little bit of a heads up to think about it.
So I was thinking, because inverted 2 waves is not a sign of a post-MI. Yeah. So I was like, this patient's so young. Maybe he has, I don't know, a thromboembolic event leading to MI, but I have no idea.
I love it. I think that that's the right conclusion. And I asked you an impossible question because I think the answer is we cannot know. It's impossible to know. You can't look at this data and make a conclusion. And I love that you stepped back and said, is this related to COVID or is it not? A persistent fever for 10 days, I think is compatible with this disease. It's unusual, but it's compatible with it. And it's enough to prompt you to be like, is there something else going on, either independent of COVID, something unrelated to this condition? Did COVID unmask a previous condition? Or does he have COVID-related disease? And you're saying that one thing that you said was, his lungs seem so fine compared to how febrile he is, and that's making me do a little bit of a disconnect. And I think that's very, very wise. Chiara, how do you think about what do you think about anything came to mind? I don't think there's an answer to this too, but anything came to mind with the medical history, the meds, the travel? What crossed your mind? I'm thinking of it. I thought of you, by the way, because I listened to a Human DX episode where you were faced with, should I talk about warehouse or travel? And you chose warehouse. So now I'm going to ask you to think about travel.
Thank you. Not so sure because he have no recent travels, 10 years without travel, I believe. So he actually lives in Canada. So actually, I don't think there could be something related with
I agree with you. And let me explain why. Travel-related diseases emerge from incubation period. When the incubation period is longer than 5 years, the only possible infections are very little. There's things like tuberculosis, brucellosis, and malaria. But these infections don't usually present so acutely. So when the incubation period, the delay between travel and syndrome, here is 5 years, is so long, the time course of the infections that usually present in a delayed manner is also very long. So the things that he could have from travel, like TB, brucella, malaria, don't usually begin so quickly. Unlike the infections with acute incubation period. So if somebody comes in and they traveled 5 days ago, their infection can be acute. So your instinct is spot on. The reason that his travel is not pertinent at all, in many ways, is because the infections that can go to sleep for 5 years and wake up in Canada 5 years later are usually much slower when they wake up. They're all sleepy and yawny and tired. They don't jump up with force. So I agree with you, 100%. Anything you want to add to that?
Not actually. I would love to hear about EKG.
Yeah, I know. We're saving the best for last to give Sukriti the most time to think. And maybe I'll ask Kara what the vital signs do for her.
Yeah, I mean, so he's febrile and tachycardic and has a high respiratory rate, but it's interesting because all of these like tell us something generally is wrong, but he's got several reasons for all of the vital findings that we have. He's been febrile for like 10 days. I would almost like give that a subacute course. Could be due to the COVID infection he had, could be due to some insidious underlying process, like a PE, although I know that's non-specific. We know that he's, tachycardic could be in response to the fever, could be in response to these cardiac findings that Sukriti is going to discuss in a second. And then the respiratory rate, he's not hypoxic, but he's like kind of tachypnic. So, makes me wonder like, oh, maybe it's not necessarily a problem with like actual oxygen exchange, like, but why is he breathing so fast? So not 100% sure there, but yeah.
I couldn't agree with you more. I think that you look at this and you're like, I'm kind of worried about this person, but I don't think you can make any more inferences, honestly. One question that commonly comes up is the fever alone causing the sinus tachycardia? And there's a rule of thumb that I don't remember that for every degree Celsius, there's about a 10 to 15% increase in the heart rate. I'll tell you that 38.5 causing a heart rate of a sinus tachycardia 132 doesn't add up. The fever is not high enough to cause a heart rate this high. So you have to analyze it completely differently and say this is sinus tachycardia independent of the fever. But I agree with you. All you can really say is, oh, this person's sick. These aren't good numbers. Good thing Mathieu is on his case and taking care of him. Hime, hello. Did I get that right?
Yeah. That was really weird though.
Really? Was it? Why?
I don't know. It's just like, I've never heard Rami called me that way before.
Hey, you know what? If you're going to change your name to that, what else am I going to call you? We need to press one more minute for the EKG. So I'm going to ask you to summarize anything you learned in Spanish. Please, please, please.
Estoy súper feliz de que Kiara ha dicho muchas cosas muy bonitas porque ella le encanta la cardio y yo odio la cardio. Bueno, no la odio, pero me cuesta muchísimo. Entonces, creo que para mí lo más importante ha sido pues lo de la taquicardia, igual que Rafa, porque es de las cosas como más básicas que a mí me cuestan muchísimo. Entonces, siempre dividir cosas, pues cualquier signo vital, como es la frecuencia cardíaca en situaciones fisiológicas y patológicas. Eso es lo que más me ha gustado hasta el momento.
Thank you. All right, I'm going to ask Sakriti to interpret the EKG and go back to our future cardiology guru, Chiara, to analyze the echo. So Sakriti, tell us what you think about the EKG, and then Chiara, please jump in with the echo afterwards.
Ravi, with the time that you gave me to think about this, I feel like there's so much pressure. And
okay, you know what? I take it back. Sakriti, there's no time at all. Tell us what you think right now, ASAP.
I don't. So I'm going to say that I don't really know what's happening. So any knowledge I have about this EKG is just related to like some random points that I know from MCQs.
Join the club.
Before I confuse anybody else, maybe you could help me with this.
Yeah. Here, let's start with one question. When you see high voltages, what does that mean to you?
I think of an enlarged ventricle.
Yeah.
If it's the left, then it's a left axis deviation.
If we keep it simple and we see that the voltages are really high, that means there's a lot of myocardium, right? Just keep it simple. So then the question is, why would you have a lot of myocardium? What do you think?
Have hypertrophy.
Yeah.
Or dilation. I don't know if dilation does it.
You know, dilation usually causes thinning of the myocardium, so the heart gets big and the myocardium gets thinner. So what you're saying, okay, there's a lot more myocardium. And the question is it physiological increase in myocardium or pathological increase in myocardium? So why would somebody's myocardium get bigger and bigger and thicker physiologically in response to what?
Hypertension.
Yeah, 100%. You can have hypertension is the most common cause of LVH or thickening of the ventricle. What if there was no hypertension? Can you think of any other ways that the ventricle is under high pressure but there's no hypertension? And I'll give you a clue. There's a murmur right here.
Anemia.
Close. You're thinking of a flow murmur. Think of how you can have pressure on the ventricle without hypertension. And think about what the aortic valve can do. I know you got this. So I'm going to give you one more clue. There's something wrong with the aortic valve. It causes high pressure on the ventricle.
And aortic stenosis.
Yes, 100%. Basically, aortic stenosis is having hypertension on the ventricle without systemic hypertension. And that's the second most common cause. So how can the ventricle get thicker and thicker? It's because, whoa, there's so much pressure on me, and that pressure can be from systemic hypertension or local hypertension. And that's what aortic stenosis is. It's just local hypertension right here in the LV. So what do you think? Do you think this young person, do you think he has a reasonable chance of having aortic stenosis?
No, it would be uncommon given his age.
Yeah, 100%. Most people are like 60, 70, right? Do you think he's reasonable to have hypertension?
I see no reason why he should have.
100%. So this is a big clue, Sakriti. If you see LVH, you should be like, what's the blood pressure and is there a murmur? And in him, you don't know the prior blood pressure, but you're like, it's probably normal. He's 20 and he's otherwise healthy, and he's not going to have aortic stenosis. So he must have another reason to have thickening. And I will tell you the most common reason that young people have thickening is they have what's called athlete's heart. is they're very athletic and fit, and their left ventricle gets thick and is responding to the exercise that they do. Can you think of a pathological condition where the LV is thick without any physiological reason, like hypertension, aortic stenosis, or athlete's heart?
HOCM.
Yeah. And hypertrophic cardiomyopathy is an important consideration to think about. And the clue to think about it is it's usually in young, it can present in any age group, but the symmetric T-wave inversions are concerning for it. And there are many EKG patterns of hypertrophic cardiomyopathy, but one of them is the pattern that you're seeing here, is tall voltages with T-wave inversions diffusely. That's not necessarily pathognomonic of it, but something that you have to think about. Awesome. So I didn't take much away from this EKG apart from, oh, there's LVH, but there's no good reason to have LVH. Could this be athlete's heart, or could this be hypertrophic cardiomyopathy? Chiara, what did you think about the echo?
Well, it's just kind of consistent with the EKG, because I don't know why it says right ventricular is smaller than left ventricular, because it's supposed to be like it, right?
Yes. That's what Matthew said. As expected.
So I don't know if it is because left ventricle is very big in compared to right ventricle, and that could be also consistent with some kind of left ventricle hypertrophy. But as you said, why a 20-year-old patient will have a left ventricle hypertrophy? So I'm not so sure if it's because aortic valve stenosis or uncontrolled hypertension, because it's not very clear for this age. But two etiologies are very concerned for me. One, if I forgot the word, hypertrophic cardiomyopathy that can present at any age. And one other etiology that I'm concerned about is some sort of infiltrative disease. And I'm not so sure if there are case reports of infiltrative disease with COVID-19, but COVID-19 can do everything. So
100%.
that it will be a concern for me. And well, an apex with concern for regional wall abnormalities. Is this a sequela of any ischemic event? And that could be consistent with the diffuse inverted T waves, but diffuse inverted T waves are most common presented in acute myocardial infarction, and not that chronic. So maybe there is a ischemic event we haven't seen, and that is that could lead to an tachycardia, maybe some tachycardia. I forgot the word, but any cause of tachycardia, not sinus tachycardia.
I love it. You're already an ultrasonographer. I have nothing to add to your addition. This is wonderful. And maybe I can ask for the chat to try to get problem representation in English, Spanish, and Portuguese, and we'll put them up on the whiteboard. So please put in your problem representations, and I will try to summarize what we learned. I think we learned, Rafa taught us the fever should make us step back, and while it's compatible with COVID, should make us question whether something else is going on, either a complication of COVID or completely independent of COVID. And Chiara was like, you know what, I'm not making much of the travel history. And that's because the travel history is distant and the syndrome is acute, and there's a clash. If the travel history is distant and the syndrome is subacute to chronic, it's possible. Things like TB can reactivate many years later and reactivate slowly. So if the travel history is distant and the syndrome is acute, they're probably not compatible. And then Chiara taught us to say, hey, you can't interpret much more from the vital signs than that the patient is very, very sick. And the rule of thumb about the heart rate and the fever, like the heart rate is way higher than the fever would suggest. And then Sukriti went through an approach to LVH, essentially physiologic hypertension, aortic stenosis, athlete's heart, pathologic hypertrophic cardiomyopathy. And then I can't even begin to summarize Chiara's advanced echo points. So I'll have to have you listen to her because I actually don't know any of that stuff. All I know is I hear Apex and I think Takatsubo, but that's probably not a play today. Matthew, maybe you can tell us what you were thinking at this point in real time and maybe how the case evolved.
Okay, so I also realized that I said I would give you the physical examination with that, which I didn't do. So he looked moderately sick, like a C- on the eyeball test, I'd say. ENT was unremarkable. There was no murmur. All limbs were perfused. The lungs had some rhonchi bilaterally. He was breathing a bit fast, but without any distress. Abdomen was soft and tender. The neuro exam was normal, and skin exam was normal as well. So that was the 5 first minutes. At this point, the tachycardia seems a bit, as you said, the tachycardia seems a bit out of proportion. But his general status was making me think, well, he's COVID and he's still febrile. In fact, I was thinking I'll get a D-dimer, it's going to be positive. I'll CTPA him, I'll rule out P, and I'll send him home. At this point, that was basically the thoughts. The ECG was a bit concerning, especially since I didn't have a prior one. But this kind of pattern, we sometimes see those in young people, especially from certain nationality. And I was thinking that might be an outpatient TTE. Then I got the labs. As expected, the D-dimer was like marginally elevated. The big surprise was this hemoglobin, which was 75, which was totally unexpected, with a VGM of 56.
Matthew, can I just jump in to clarify? Is the hematocrit 75?
That's the hemoglobin.
Oh, is it half of what it should be?
Yes.
Okay. All right. So I think Chiara, it's 7.5 from the units that we're using.
Yes, that's 7.5. Yeah, 7.5 VGM 56. Platelets were 161. White blood cells 7. I see Drew in the chat. And VGM is the MCV. Sorry. Trope was negative. CRP was 50. Ferritin was 36. Blood gas was like a bicarb of 20 for a pH of 7.35. Coags were normal. Lactate were normal. So I'll fast forward a little bit. The D-dimer were 600. So I asked for CTPA, which was negative for PE, and showed ground glass opacities in both lugs compatible with COVID. No signs of consolidation or anything that could make us think of a bacterial superinfection. I got a second EKG an hour later, which surprisingly showed dynamic changes. The inverted T wave in the anterior lead had normalized, and the T wave remained inverted in the lateral and inferior leads. I asked for a second troponin 3 hours later, which remained negative. And I went back to see the patient, did a DRE, which was negative for blood, and re-questioned the patient. And it never had rectorrhea, melena, or any kind of bleeding that he noticed.
Unbelievable.
And I'll let you reflect on those things.
Yeah. Uh-oh, good thing I have a dream team with me today. Okay.
Oh, and just to add, is the vitals remain static throughout the whole shift?
Amazing.
Like marginal tachycardia, but maintain his blood pressure. But you could say it was orthostatic. At one point, he verticalized and had a quasi syncope.
Amazing. Perfect. Super helpful. Thank you, Matthew. What an intriguing case. And Rafa, I'll come to you in a moment to help us think about what the EKG and the troponin do for us. But maybe, Kara, we can start with microcytic anemia. What do you think about the microcytic anemia?
I mean, most commonly it's iron deficiency or like there's an insidious bleed somewhere, but this is a young person, and so I'm not going to go, oh, there's like a GI bleed that we're not catching. But it's a microcytic anemia with a low platelet count. And so I don't know, maybe like possibly everyone's talking about thalassemia in the chat because that's another possibility. And then I don't know. I'm wondering, like, he's got a high, like, borderline B dimer and elevated CRP. So, like, is he hemolyzing? Don't know. That's kind of where I'm at.
Yeah, no, I think that, like, if you make a list of causes of microcytic anemia, it really is thalassemia and iron deficiency as the leading causes. And thalassemia is not a bad idea in somebody who's coming in from the Mediterranean basin, specifically beta thal. And then you look at the ferritin and you're like, you know what? That's compatible with iron deficiency. But people with thalassemia aren't immune to having iron deficiency. So there's no reason he can't have both. And I think the tension in this case is that he could have a baseline microcytic anemia from iron deficiency or from thalassemia with a baseline hemoglobin of 10 or 11. Does he have an acute anemia right now because of hemolysis or because of blood loss in the face of his current syndrome? But I think you're spot on. You have to step back and be like, I know the causes of microcytic anemia are iron deficiency, and I'm very confident he has iron deficiency because his ferritin is less than 50. Does he have a concomitant thalassemia? Possibly. Why? Well, he's from a region where thalassemia is not uncommon, and two, his MCV is super low, super low. The MCV with iron deficiency parallels the degree of iron deficiency. Thalassemia, in contrast, they typically have a very low MCV independent of the number of red blood cells. So let me show you what I mean by that. That was a little vague. So here, I think we have reason to suspect thalassemia based on where he's from and just how low the MCV is. But here, this computer's so slow today. I'm giving Rafa more time and therefore more pressure to think about the EKG. Here, one sec. Okay, where are we? So this is the key concept for MCV and time. So in thalassemia, the MCV is always super low and stays stable. It's always like 50, 60-ish, 70-ish, and doesn't change over time. In iron deficiency, it slowly drops over time. The worse iron deficiency, the worse the MCV. In him, his MCV is 56. It's super low. So does he have thalassemia, superimposed iron deficiency? And does he have an acute process today, like worsening bleeding or hemolysis? I think you'd have to really analyze all those possibilities. A rectal exam is very good in ruling out acute severe blood loss, but you can't rule out chronic blood loss for sure. Rafa, where are you at with the EKGs? What does that do for you?
Good question.
Thank you.
Let me just begin to say I don't know. And also, I have this theory, but you can teach me if it's wrong, okay? So this patient had a persistent tachycardia. Maybe he had like an injury due to this persistent tachycardia leading to the inverted T wave due to, I don't know, regional ischemia. This patient had on the first, like, mobility abnormalities, or am I dreaming, or was it written in the whiteboard? I don't see it. Maybe I'm confusing with another question that I saw earlier. So maybe the persistent tachycardia led to I don't know, a lesion in his heart leading to the inverted T wave, but I don't know what to think about it, to be honest with you.
100%. I completely agree with you. What we get repeat EKGs all the time in patients, and what we're trying to see is the syndrome evolving, and dynamic changes, evolution means the diagnosis is evolving, and it's usually consistent with a myocardial infarction because the myocardial infarction evolves and gets worse and worse and worse and worse. Static changes, an unchanged EKG, is less compatible with a myocardial infarction because a myocardial infarction untreated evolves. So when we hear the word dynamic, we're saying the EKG is changing and our concern for myocardial infarction goes up. But the EKG can be dynamic because the other syndrome can be dynamic. So if you come in and you have hypertension-induced EKG changes and you control the hypertension, guess what happens to the EKG? It gets better. So here, you're worried that this EKG represents myocardial infarction because nothing else is changing, and yet the EKG is, but the troponin is negative. So I will tell you, this case is literally, I really feel for Matthew, it's impossible to make progress. Why? I would say that the sinus tachycardia is very concerning, and the most morbid thing that's been ruled out as a COVID complication, PE, is out. The persistent fever may be COVID, maybe something else. The sinus tachycardia is completely unexplained, but maybe from acute blood loss, maybe from something else. His anemia may be iron deficiency, thalassemia, acute blood loss, hemolysis. Everything could be happening.
Or lead poisoning.
Or lead poisoning, yes. Step one, nerd. Absolutely. So, how do you make progress? I think you go back to the sinus tachycardia and say, is there any other reason to think he is in shock? It's not a PE, it's not a pericardial effusion. Could he have acute hemorrhagic shock and his hemoglobin is going to be lower next time? Maybe. Does he have cardiogenic shock? Maybe, because his EKGs are evolving. Does he have sepsis? Maybe, because he is febrile. Is there anything in the sympathetic toxicity that we should check? Maybe a TSH, because it's not uncommon. But I think this is very tricky because you can make a case for distributive physiology because he has fever and he's tachycardic and hypotensive. You can make a case for cardiogenic physiology because his EKG is changing and he's tachycardic and he's hypotensive. And you can make a case for hypovolemic shock because he's tachycardic and he's anemic. So what do? I think you do them as much as you can for each of those things. You think about antibiotics, but you probably don't need them in COVID. You think about fluid resuscitation. You think about checking a hemoglobin soon, and you think about getting an echo in the near future to clarify these changes. But more importantly, you ask a much smarter doctor than you in the form of Matthew to tell us what he was thinking and how he took this case home.
So from there, I repeated another trope, another hemoglobin. I had an hemolysis panel plus a TSH a few hours later. That didn't show any sign of hemolysis. It showed a hemoglobin that dropped from 75 to 67 over a couple of hours, but in the meanwhile, he received about 1.5 liters of crystalline, and all his cell lines seems to have been decreasing proportionally. So I suspect that was delusional. TSH was normal. As I said, no hemolysis. Trope remained negative. Then I transfused him 1 unit of blood. And transfused 1 unit of blood. He remained clinically stable. I also, someone mentioned the platelets earlier. I was also intrigued by the platelets that were not higher than that in someone who's one, inflamed, and two, is in a low iron state. I would have expected this platelet to be much higher. So I suspect there's dual pathology that explain his hematological abnormalities. So for his anemia, I asked GI to see him in the morning. They're probably gonna have to scope him, see if there's an answer. Then I'll also ask internal medicine. They probably saw him this morning. And I asked my emergency colleague who took over at midnight to keep an eye on his hemoglobin overnight. They keep an eye on him. Concerning about his ECG, my differential included well, type 2 ischemia, which would be super unusual in someone 20 years old. I don't expect him to have abnormal coronaries, but still he had some changes that seem to be dynamic, and the dynamic nature of it seems to correlate for when I gave him fluid, gave him some blood. So maybe other possibilities, as you guys mentioned, myocarditis, but again, myocarditis should have elevated troponin. So that speaks against it. Other possibility, which I'm wondering if that's not the case, if he doesn't have a bit of stress cardiomyopathy, a bit of Takotsubo. On my echo, there was potentially some apex regional wall motion abnormality. So that's possible. Would fit his presentation of 10 days of being super adrenergic with his COVID. And the other possibility is that he has some long-standing cardiomyopathy or athlete's art that we're just uncovering now that he comes to us. So cardiology was going to see him this morning, and he'll get a formal TT. So that's pretty much it. The other thought that crossed my mind last night is there was so many unexplained things, so many things that seems a bit disproportionate. Yeah. And with this bicytopenia and COVID and inflammatory state, I wonder, is that HLH? Yeah. So I sent a triglyceride, which came back normal. So I don't think so, but I thought that was one, because it's well described with COVID.
Yeah. Cool. I've never heard an ER doctor send a triglyceride level. So I've heard it. That's just incredible. Wow. You know, I'm struck by how this is one of the very few cases of real life on Virtual Morning Report. People are so incredible presenting cases that they've thought about, wrapped, and they know exactly how to break it down, and they know the conclusion. And it's so refreshing to occasionally have real life. This is real life. This happens to us all the time. And I think I learned so much from going through this case with you. Thank you so much for bringing it. And I hope that the next time you're here, you can tell us what happened to the patient, what the case conclusion was. It certainly were keeping us on the edge of our seats.
I promise next Saturday I'll be there, and I'll give you what happened.
Amazing. We cannot wait. Really, really cannot wait. In the meantime, maybe we can go around the group and have somebody emphasize one thing they learned, and end with Rafa to take the teaching points from the top. So Kara, if you want to start us off, one thing you learned, go to Chiara, Sakriti, and then Rafa to end their session.
Yeah, I'm usually so wrapped up in like discussing that I don't have a chance to look at the chat. And so this roundtable has made it a cool opportunity to learn some things about thalassemia that I didn't know before. And then Matthew, if you have a second, can you clarify for Rob and I the connection between iron deficiency anemia and platelet count? Because I don't think I'm aware of that connection. You mentioned something about there being a relationship there.
Well, normally, if you have iron deficiency anemia, you should be regenerating. So your bone marrow should be overworking, and it usually translates in platelets as are a little bit elevated. It certainly shouldn't be low.
Amazing. Thank you so much. Chiara.
Wow, thank you so much, Matthew, for this case. And I learned a lot. I don't have just one teaching point. So can't wait for next Saturday final diagnosis.
Amazing. My learning point before I pass the mic to Sakriti is that Maria can stay awake like a champ despite working overnight. Though I did see a couple of glimpses of snoozing there, which is quite a treat. Hi. Sakriti, what did you learn?
I mean, I learned a lot from this case, but I think the thing that's really going to stick with me, because this was something I didn't know, was the approach to the high voltage in the EKG lead. And maybe Rafa will elaborate it more in the teaching point, so I won't say anything, but yeah.
All right, Rafa, take us home, my friend.
Okay, so thank you everyone involved. Thank you, Matthew, for the case. Really, really interesting and very humbling. So we had a 20-year-old patient post-COVID with persistent tachycardia, and the Sakriti started reminding us that the severity of the disease increased with age and the presence of comorbidities, and there are new variants that are emerging here in Brazil, it's an example. For example, in the hospital that I go to, there are a lot of young adults in the ICU, so things are really complicated. And COVID is also associated with unusual complications like thromboembolic risk, increase in thromboembolic risk, anosmia, and myocarditis. And then Ravi taught us about the persistent tachycardia, which could be intrinsic, for example, ventricular tachycardia or supraventricular tachycardia, but also extrinsic causes, which is sinus tachycardia. They could be physiological or pathological response. It could be seen in shock, for example, distributive, cardiogenic, hypovolemic, obstructive, but also in fever, sympathetic toxicity, which could be exogenous, like, for example, cocaine, albuterol, and ethanol withdrawal, but also endogenous, like pheochromocytoma, anxiety, pain, hypoglycemia, and always look for the EKG to differentiate both. And then when it comes to shortness of breath, CP has this amazing schema, and common things being common, it's usually a cardiovascular or pulmonary problem. Cardiovascular could be a myocardium problem like heart failure, but also coronary artery disease. The pericardium could be involved leading to constrictive or tamponade, but also electoral problems like arrhythmia. And the pulmonary processes include the airway, for example, asthma, COPD, the parenchyma, ILD, the alveoli, which could be filled with water, blood, poo. Rabi always remind us to think about the alveolar singing, the vasculature, pulmonary embolism, pulmonary hypertension, but also the pleura, the chest wall like obesity, the neuromuscular disorders like myasthenia, but also hematology like anemia and others as well, like acidosis and anxiety. And then the biggest takeaway from me from this case is the high voltage zone EKG. Rabi taught us that it's a lot of myocardium, it's concentric hypertrophy, and we can hear an aspar, which is a sign of non-compliant heart, a diastolic dysfunction that could be seen in hypertrophic cardiomyopathy, but also a response to hypertension, aortic stenosis, and there is this step 1 pearl for the rishataxia, but also athlete's heart. Another pearl is that aspar is normal in older adults, but abnormal in young patients and children. And in fact, and then finally, we talked a little bit about microcytic anemia, which can be divided in defective globe chain synthesis like thalassemia, or defective heme synthesis like anemia of chronic disease, iron deficiency, and lead poisoning. So thank you, everyone. I hope everyone had a good time discussing and learning today with us.